Dr. Sridhar Kalyanasundaram, senior colleague and neonatologist at Antenatal Emirat Hospital, a hospital which he's just been telling me that has been really expanding and sort of encompassing a lot of the services to do with neonates. Dr. Sundaram is going to speak to us about current updates on antenatal steroids. And may I take this opportunity to thank all the people who have attended in person and the hundreds of those who have been attending online regarding their active engagement and the quality of their participation. So the floor is yours, Sundar.
Good morning, everyone. I would like to thank the organizers for the excellent job they are doing, huge virtual audience and continuing despite the difficult market situation as well. And Dr. Dova has been supporting this conference for a long time, doing a great job with that. And Anne and the team are doing an excellent job as well. Thank you for that. So antenatal steroids, all of you are quite familiar with the topic, but the focus is on the recent changes. And I will try to skim through the initial aspects and then we will focus on the recent changes as well. So I will outline the history of the use of antenatal steroids. We will review the evidence base to support the use in different gestational age groups and then the recent changes as I mentioned. So we had the World Prematurity Day on the 17th of November. All of you must have seen in the press and probably your unit was involved in that as well. So 10% of the babies in the world are premature. And obviously the rate of prematurity ranges from 8% in the developed world to as high as 17% in the poorer countries in Africa. Respiratory distress is still a major cause of morbidity and mortality in the premature babies. And as I said, we all know the effect of antenatal steroids. So they reduce the risk and severity of RDS and they improve the outcome. We might have heard of Liggins, Professor Liggins and Hovey's randomized trial in 1972. This demonstrated a reduction in the incidence of RDS and mortality, and this can be called as a single greatest collaboration between an obstetrician and a pediatric colleague. And the intervention they described has saved the lives of thousands of tiny premature babies. Dr. Graham Liggins was an obstetrician who studied the effect of cortisol in the labor process of sheep. And during the process of his experiments on labor process, he made a serendipitous discovery that the fetuses who were exposed to the steroid actually survived more and they had less severe respiratory distress. He then decided to conduct a randomized study on babies, human babies, with Dr. Hovey, who was a neonatologist, and they were both in New Zealand. 282 women at risk of premature delivery were randomly assigned to receive either standard treatment or the standard treatment plus 2 doses of steroid, and the steroid they used was betamethasone. Early neonatal deaths was 14% in the control group and 3.2% in the steroid group. 24% of the controls had RDS, but only 4.3% of those given steroids. So this was obviously very significant. So this is showing you the two geniuses at work. So Professor Liggins is no more, and this is him with Dr. Hovey. So the impetus to the Cochrane collaboration came up from the fact that even though this clear discovery was made in 1972 in a published study, the impact on the management of premature babies was not till meta-analysis was done as close to 89 to 91. So we have multiple studies showing benefits, and the forest plot of that is now the symbol of the Cochrane collaboration. Obviously, the Cochrane collaboration doesn't deal only with neonatal problems, it deals with the entire world's evidence-based medicine. So that is the impetus for the movement we call evidence-based medicine, and the symbol is from the study on antenatal steroids. That's an interesting fact in history. So how do steroids work? I won't dwell much into this, but mainly it improves lung mechanics and gas exchange, and it increases surfactant production. So this increase in surfactant production contributes to most of the benefits, but the improved lung mechanics by stabilization of the membrane, the shift of the electrolytes across the membrane, it stabilizes membranes in other parts of the body as well, like the brain, the gut, and so on. So it accelerates maturation not only in the lung but in other organs. The effect on reduced rate of IVH and NEC is through not only the improved stability of the baby from reduced severity of RDS, but also a direct impact on the membrane stabilization. So in March 2017, the Cochrane review was updated. So 32% reduction in neonatal deaths, 35% reduction in respiratory distress syndrome, 45% reduction in moderate and severe RDS, 46% in IVH rate, 54% reduction in NEC, 43% reduction in systemic infection in the first 48 hours. So the reduction in infection could be because of the reduced severity of illness and less intervention needed in these babies. So all these are very important, and obviously there is no doubt that if you have the chance to use it, better to use it when there is prematurity. In a woman at risk of early preterm imminent birth, use a single course of antenatal steroids if the gestational age is 34 weeks and 6 days or less, when the preterm birth is planned or expected within the next 7 days, even if birth is likely within 24 hours. So the reason we say that is the effect of steroid is better after 24 hours of the first dose, but it does have an immediate effect as well, 4 to 6 hours, because of the release of the surfactant preformed and stored in the lamellar body. So except in the extreme preterm babies who don't have much of stored surfactant, this effect will be significant. And this should be regardless of the reason the woman is considered at risk of preterm birth. And the number needed to treat is very significant. Before 31 weeks, 1 case of RDS is prevented for every 5 women treated, which is one of the best benefits you can see in medicine. So the optimal time to administer is when birth is planned or expected within the next 48 hours. And as I said, from 24 hours to 7 days of administration is the maximum benefit. The nature of the steroid given does impact this. So I would come to Dr. Alan Job's study in the next couple of slides when we discuss the pharmacokinetics of the medication. But remember that the betamethasone acetate has a slightly longer half-life. And so a combination, the celestone that was given in US and UK has a longer half-life for this because of the acetate. And so the 7 days effect is variable depending on what product you're using. There is no clear benefit under 24 hours on respiratory distress, but there is some benefit on mortality. Where appropriate, we should monitor the mother for signs of puerperal sepsis. All the women at high risk of preterm delivery start a course even with if 1 dose. Suppose she is coming in labor and you don't know she will continue for a few hours or she will deliver quickly, you still give it because the effect cannot be predicted, but still you may get some benefit. And where it is safe, where there is no risk of maternal chorioamnionitis, you can give tocolytic drugs to gain time to administer the steroids. Where appropriate, estimate the risk of preterm birth by considering the use of adjunct prediction tests, including fetal fibronectin and assessment of cervical length. This becomes very important because you shouldn't give the steroids with a low threshold. Where you think there is a definite risk of delivery, you give it, but where in doubt, you may wait to confirm by these tests, because as I said, we don't keep giving it. We want to give a course when it is definitely indicated. Repeated courses are not ideal. So between the drugs used, betamethasone and dexamethasone are the preferred choices because these are not extensively metabolized by the placental enzyme, 11-beta-hydroxysteroid dehydrogenase type 2. So prednisolone, for example, is metabolized with this medication, so it's not a good choice. And the efficacy of alternative dose regimens is unproven. So I know some units may give dexamethasone with a similar dose as betamethasone, but the half-life is different. It's a shorter half-life for dexamethasone. So better to stick with what is a proven course. It's an intramuscular injection. So if units using dexamethasone want to reduce the number of IM injections in the mother, they may use this. In UK, I know many units were using dexamethasone with the betamethasone dosage, but remember that its evidence is low. The comparison of the 2 steroids shows variable results. 2 studies showing less PVL and better long-term outcome with betamethasone, and 2 studies showing better pulmonary outcome and less IVH with dexamethasone. However, statistically, this doesn't come to significance. So your local availability would be the key factor. One of the points that was highlighted a few years ago was the use of betamethasone preparation with sulfite. So sulfite itself is damaging to the fetal brain. So it can cross over and it can damage the baby. And this came to the fore in developing countries where the cheaper sulfite preparation was used and it caused injury. So this has been taken out of the market. Most people are familiar with that, but it's important to focus that we may do harm by trying to cut costs. This is the paper I mentioned by Professor Job. Alan Job, all of you know, is a pioneer in the field with chronic lung disease definition and so on. And he looked at the pharmacokinetics, and betamethasone propionate and acetate combination is used, as I said, in most countries in Europe and in US. And the acetate has a much longer half-life, so the fetus may be exposed to a higher dose for a longer time if the mother doesn't go on to deliver after the course of steroids, so which happens quite often. So if you look at statistics, 30 to 40% of the mothers deliver after receiving antenatal steroids within a week, and 60% do not deliver. That means we are not strict enough with the criteria we use to give the steroids. So dexamethasone and betamethasone propionate have similar action. So propionate preparation of betamethasone can be used. The acetate preparation, here we are using betnesol, which doesn't have the acetate, so it's fine. The authors argue for better patient selection. They don't say that you shouldn't use acetate formulation, but you don't use it with a low threshold, so you should make sure the patient is likely to deliver soon. Use with caution if there is maternal infection, especially tuberculosis, where the steroids may cause a flare-up. Don't delay delivery if corium ninetase is present. That is just for the benefit of steroids. Don't give tocolytics if there is a risk of maternal infection. As we know, maternal infection increases the cytokine storm, and that is linked to both BPD and periventricular leukomalacia and abnormal neurodevelopment in the baby. It can be safely used with prolonged premature rupture of membranes, however, not in repeated courses. The timing is important in these cases. It can be used with multiple pregnancy, can be used with maternal hypertension or PAH. And in maternal diabetes, it is used, but the effect may not be as good, and you should use with caution. Monitor the mother's blood sugar more stringently. The side effects may include reduced fetal movement, reduced biophysical profile score, and reduced fetal heart rate variability. So you can inform the mother to be aware of this, but at the same time, don't delay review if there is a significant concern. There may be a concern with immune suppression. There is no significant effect on blood pressure as it has a minimal mineralocorticoid activity. In a diabetic mother, the risk of hyperglycemia from 12 hours to day 5 post-dose is important to be monitored as well. I mentioned that we shouldn't rush to give the steroid because the repeat courses are not very evidence-based, and we should be careful. More than one repeat is not advised anywhere. So we should use repeat courses when a woman is at risk of early preterm imminent birth following a single course. The gestational age here is 32 weeks and 6 days. This is according to the Australian New Zealand guideline. I'll come to the RCPCH and the ACOG guideline next. When the preterm birth is planned or expected within the next 7 days, even if the birth is likely within 24 hours, not less than 7 to 14 days following a single course of antenatal steroids, and the clinical decision to use a repeat dose should be based on an high ongoing risk assessment for the risk of preterm birth. The RCOG suggests only if the initial course is given under 26 weeks and impending preterm delivery before 32 weeks. The ACOG has a little more liberal guideline that if she is delivering less than 34 weeks and the previous course was given more than 14 days previously, you can give. So you can follow any of these guidelines, but remember that if the course was given much before, like if she had come with threatened labor at 25 weeks and she didn't deliver and she's coming at 28 weeks, you should definitely give. Again, there is an option to give a single dose rather than a single course, so you can give either of them. If you don't want to expose too much, at least a single dose can be given, and if the baby delivers more than 24 hours from that, the benefit will be reasonable. So this is important to discuss with your obstetric colleagues, that it does make a big difference in the babies who are coming really premature. Don't rely on the steroid that was given more than a week ago. At the same time, you have to audit and tighten your criteria that you're using the first dose, so you don't end up in this situation frequently. So why should we worry about multiple courses? Because there is a risk. The baby can grow less, can have a reduced head circumference. Experimental studies in animals have shown impact on the developing brain. The cerebellum can be smaller in the babies who are exposed to multiple courses, and You might be familiar that in the early 90s, multiple courses was given for pre-PROM or twin pregnancies, and they studied these babies who did poorly in neurodevelopment as well. So there may be an increased risk of cerebral palsy if you are repeatedly giving, not with a single repeat course, but if you give multiple repeated courses. So it's not to be given as candy. The benefit, it should be a reduced RDS as well as a reduced composite infant morbidity score. So I explained this already. Avoid routine use based on gestation cutoff. Avoid prophylactic steroids in multiple pregnancy unless there is an evidence that she is likely to deliver soon. There is no evidence for routine repeat antenatal steroids in prolonged premature rupture. So only give it when she's likely to deliver. Careful diagnosis, as I mentioned, using tools like the cervical length measurement or the fetal fibronectin. And when we are repeating the course, inform the parents about the lack of evidence. I would request all of you to go through the detailed document published recently by the ACOG on this topic as well. And coming to the recent developments, I mean, the couple of papers, editorials in BMJ and by Alan Job as well, looking at antenatal steroids in low and middle income countries. And the impetus for this came from the study published, the ALPS study, the antenatal corticosteroid trial in preterm births in developing countries. So they started questioning whether the same criteria that is used in the developed world can be used in the developing world. Is it safe to use antenatal steroids? And we know that majority of the premature babies in the world are born in the developing countries. Most of the evidence base, however, comes from studies in the developed countries for obvious reasons. So out of the 29 studies included in the Cochrane meta-analysis, 27 were done in the developed world. So the ALPS study in 2015 was published, and this was a community-based cluster randomized trial conducted in 6 low and middle income countries listed there. The aim was to evaluate the feasibility, effectiveness, and safety of a multifaceted intervention designed to increase the use of antenatal steroids at all levels of healthcare. The intervention included commodity procurement of the steroid, training and tools for healthcare providers to recognize women at risk. However, the weakness of the study was that they recognized risk by expected size. They assumed that there won't be a way to assess the gestation correctly. Many of these mothers were not booked early. So they said wherever the expected weight of the fetus is less than the 5th centile, they assume that it is a premature baby. So this assumption was a mistake, as you would know from the results. The primary outcome was neonatal death at 28 completed days among the live-born infants at less than the 5th percentile for the birth weight. And they included 101 clusters in 6 countries, capturing nearly 100,000 live births. The use of steroids increased in the intervention group for women at less than the 5th percentile, but also for all women regardless of the baby's birth weight. So they did manage to give more steroids, but it also means that only 16% of the women who were given steroids ultimately gave birth to less than 5th centile. So this shows how poorly focused the group was. They were giving, I told you not to use steroids like candy, but they were using it like sweet candy. And they were highlighting substantial overdiagnosis of the imminent preterm birth and over-treatment with antenatal steroids. So any study which is done like this is doomed to fail, and that's what happened. And actually they caused more confusion by bringing out that antenatal steroid use had no effect on neonatal deaths in the high-risk group. However, among all births, there was an increased risk of neonatal mortality and stillbirth, and there was an increased risk of infection. And this put a spanner in the works on the use of steroids in the developing world. However, most of the obstetricians practicing had seen the effect of antenatal steroids in reducing respiratory distress, so they didn't change the practice. But the WHO did issue a statement which confirmed the clear-cut approach to use of steroids in this group. Gestational age assessment can be accurately undertaken. Preterm birth should be considered imminent. There is no clinical evidence of maternal infection. Adequate care should be available. So you should have some basic level of intensive care to look after the premature baby, at least at the initial phase, like starting CPAP, for example. And the preterm newborn can receive adequate care if needed. So these are the criteria. It's almost confirming what is followed in the Western countries. So it's nothing new, but it said don't use it with a low threshold. And they also organized or provided impetus through the Bill Gates Foundation for further studies, and the WHO action trial was published last year. And this thankfully was done with better methodology, and they included 2,852 women and 3,070 fetuses, 29 units in these countries, and the trial was stopped for benefit after the second interim analysis. So they didn't complete the study because the benefit was evident if you use the steroids appropriately. So they found a reduced risk of death. So 19% versus 23%, and there was no increased risk of infection. So if used appropriately, it works equally well in the low-income countries. So you should be stringent in the criteria as you would in any other setup. The ALPS study by Bannerman et al. In 2016 changed the approach to the use of steroids in the late preterm babies. So the previous use of recommendation for antenatal steroid use was not extended to babies after 34 weeks because we didn't have data in that group, and because we believed that most of these babies would do well at this gestation. However, it's clear that the infants born during the late preterm period have more complications than term babies, including respiratory distress. So they recruited women with singleton pregnancy at 34 to 36 weeks with a high probability of delivery in the late preterm period as defined here. The women were ineligible if she had received antenatal steroids previously during the pregnancy. So the repeat course does not apply here. As I showed you, the ACOG criteria was 34 weeks and below. So the late preterms are not included in the repeat course of steroids. She was expected to deliver in less than 12 hours for any reason, then you don't give it as well, because the benefit for this group is not going to be as good. The primary outcome was need for respiratory support within 72 hours, defined as CPAP or high flow supplemental oxygen with FiO2 more than 0.3 for 4 hours, or mechanical ventilation or ECMO. There were 24,000 women screened and 2,831 eligible participants underwent randomization, and this is the two groups. And the baseline characteristics were similar, except for the maternal age and the ethnicity. The rate of the primary outcome was as expected lower in the betamethasone group, so 11.6 versus 14.4, which was significant. And there was increased risk of hypoglycemia in the betamethasone group. So they had a word of caution that if you are using it, watch these babies more closely. But 34 to 36 week babies, by any NICU protocol or the postnatal ward protocol, the babies would be screened for hypoglycemia anyway because of the prematurity. So it didn't add anything to their management. It was just a caution that the rate of hypoglycemia was slightly more. And that is one of the reasons why you don't want to give it where the delivery is imminent. And it was uniformly shown to reduce TTN, BPD, composite outcome of respiratory distress syndrome, and the rate of resuscitation at birth was reduced as well, because most of these babies who have TTN are shown to need some IPPV at birth as well. And the surfactant use was reduced by half in this group. Because it's a good number of babies who are born at this gestation, I mean, you might be clear that 10% of the preterm babies, only 1.5% are born below 32 weeks. So 8% of the premature babies are born at 34 to 36 weeks. So it's a big group of babies we are talking about, the number of babies. So it does make over time a significant reduction. They concluded that the administration of antenatal betamethasone in women at risk of late preterm delivery significantly reduced the rate of respiratory complications, and the ACOG as well as other bodies changed the guideline. It's very important when we are using steroids that we look at long-term outcome, because we know postnatal steroids triggered a bit of storm, because we used to use it very frequently in the late 90s and early 2000s, and we found that there was increased risk of cerebral palsy with early postnatal steroids. So the same impact may happen if you overuse antenatal steroids, and thankfully, I mean, the caution is there, but it's not been proven. And there was also studies to look at use in term elective LSCS, Stookfield. That is a main study. Still, there are 2 or 3 studies available, and they showed benefit in reducing the rate of TTN from 4% to 2%. Time over or 5 minutes? Still 5 minutes. Okay, thank you. So you can see here that the betamethasone group had significantly reduced respiratory morbidity. And you can see that the effect is more in the 37, 38 weeks, but at 39 weeks, the effect drops. So the number needed to treat will be lower in this category. So the recommendation, you can consider a course of antenatal steroids for elective cesarean section at term, and you should try to avoid it as best as you can. So don't do it before 39 weeks, but if you need to deliver before 39 weeks, you can consider a course of steroids. That's considered. There is no definitive need to give it if the parents don't agree. This is the forest plot for use in general after 34 weeks. So you can see that the steroids does reduce the risk of respiratory morbidity in this group as well. Extreme preterm, this is last part. So 24 weeks and above administered to all mothers likely to deliver within the next 7 days. We all agree that these babies would survive for 50% or more. At 23 weeks, the benefit is noted in outcome studies. You can consider where the parents are keen on giving the best chance. 22 weeks, most centers have no or very low survival, and giving steroids might give false hope. So you have to discuss clearly with the family what they want to do. And the centers like Iowa or Japan, for example, where the babies are surviving, they may start giving it routinely. In our center, you have to do case by case. And some studies show improved survival in cohorts starting from 22 weeks, but no difference in outcome at 22 weeks in the NICHD study. So the biggest cohort was published in JAMA Network Open 2018. And this study again looks at the changing practices. So you can see the proportion of eligible infants who received postnatal life support varied at gestational age. So 30% received support at 22 weeks. So about 10 years ago, this would have been 0. And 87% at 23 weeks. So again, 5 to 10 years ago, this would have been 30%. So things are evolving in neonatology. More people are starting to get hopeful. At Antenatal Emirat, we recently discharged a baby born at 22 weeks. This was the first baby that I have discharged myself, born at 22 weeks. And of the infants receiving postnatal life support, the proportion exposed to antenatal steroids increased with advancing gestational age. So 52% of the mothers. So again, the obstetrician's perception is changing. So majority start receiving at 24 and 25 weeks, 88 and 90%. For the infants born at 22 to 25 weeks gestation receiving postnatal life support, exposure to antenatal steroids was associated with improved survival without major morbidity. So even at the extreme prematurity, steroids do improve the outcome. So you may not change the respiratory outcome, but you can change the composite outcome of survival and morbidity. So the benefits was here. The reason their survival without morbidity is very low is because they include BPD as a morbidity. So it starts increasing from 4% at 22 weeks, 5% at 23 weeks. This is survival without major morbidity, including BPD. However, the rate of survival without severe IVH and severe PVL was reduced in all the groups as well. So the long-term outcome, this is the last slide. So this was a prospective cohort study. Again, this is a reference published in Acta Pediatrica a couple of months ago. And 78 children with gestational age 22 to 31 weeks born in 2004 to 2007. You can say the practice has changed a little bit since then. And they were examined at 12 years of age. The two preterm groups, very preterm and the extreme preterm. And in the extremely preterm group, administration of antenatal steroids was associated with better cognition, basic attention, word generation, and motor skills. So it's reassuring to know that the long-term developmental outcome at 12 years was still better when we use steroids, not only the survival and the respiratory morbidity. Very important to look at quality improvement. So we should monitor the policy to administer steroids so we don't miss out on eligible mothers. At the same time, we should make sure that adequate documentation is there, good collaboration between the obstetric and neonatal team, and administer the dose before transfer in case of in utero transfer. Avoiding overdose should be reviewed, as only 20 to 40% receiving steroids delivered within the 7-day course. So this number should be more than 50%. And use of tools to predict preterm labor effectively would help to reduce this as well. So in summary, antenatal steroid use has been an intervention of great importance with greatly improved outcomes. A clear knowledge of its use and limitation is very important, not only for the obstetricians, but also for the neonatologists. And the further results, the long-term results of the action study will hopefully clarify use. Of course, the study was stopped after the second interim analysis, as I told you earlier, with a benefit noticed. And in the term and near-term babies, you can individualize the approach. You can involve more role of the parents. Don't rush to give it because the long-term safety is still to be watched. With this, thank you. I don't know if we have time for a couple of questions.
Great. Thank you. Thank you very much, Dr. Sridhar, for this enlightening overview of the role of steroids antenatally. I don't know what we would have done without the steroids. It does do magics. There are a few questions coming online, but I would like to open the floor for questions if there is any burning questions from the floor. Okay, it's just What is, we would normally get concerned about the effect of steroids on the adrenals. I was hoping to hear something, from the presentation. Would you be concerned about the adrenal function?
Whenever it's a short course, we are not worried about adrenal suppression. When the course is more than 3 weeks continuously is when you start thinking of adrenal suppression. So this has no effect on the adrenal, either on the mother or on the fetus, because it's only 2 doses.
But in cases of repeated courses, as you
we don't use repeated courses anymore. So the maximum you can use is 1 course 2 weeks after the last course if they are under 34 weeks. So we don't recommend repeated courses. 1 repeat course is the maximum you can consider.
I mean, if, in case people ended by giving, more than 1 course in close proximity, would you get concerned about the adrenal function and you check on it?
To be honest, if the practice is as per the guidelines, we wouldn't reach that situation. But if they are using repeatedly, like the studies which were done in the beginning, like weekly 2 doses like that, they could have impact on the adrenal as well. But we don't encounter this in practice these days because nobody uses like that anymore.
Because even actually most of the questions coming online are concerned about the possible side effects of the steroids. For example, Anuja says, I cannot use it because of its long-term effect on the baby.
Postnatal steroids are more clearly evidence-based, especially if you use it in the first week. But antenatal steroids, we have enough evidence to say that with the current usage, it's safe enough. And of course, the repeated courses should not be used more than once maximum. That is if it is indicated. So don't give the first dose in a rush. Time it appropriately, don't overuse it. So the message is clear that it's not totally safe. You should be cautious with its use. Don't break the guidelines.
And I was asking about the choices, if you were to be given the choices between choosing the betamethasone and dexamethasone.
So I mentioned it in my presentation as well, that both are equally effective. There are conflicting evidence to support one or the other, but in practice, and the Cochrane review confirms the same, that your local availability should guide you. If you have an acetate preparation in your betamethasone, be careful not to keep repeating it as well, because that has a longer effect on the in utero exposure. So try to use a preparation with just the propionate salt.
And Priscilla claims that in a pregnant woman who has got infection, you better avoid giving steroids.
You wouldn't give tocolytic to delay the delivery, but you would still give steroids in them. If she has tuberculosis, you should be cautious. But other infections, chorioamnionitis is not a contraindication, but you wouldn't give tocolytics because you don't want the baby staying in the tummy longer than needed. So there is a risk of the fetus staying in the mother's tummy if the chorioamnionitis is prominent. You still give the steroids. It doesn't impact the risk of infection in the mother or baby, but you don't give tocolytics in this group because you want to deliver them soon.
And there is a question about any cutoff age for using any cutoff gestational age.
Yes, I mean, that is multiple studies. So 22 weeks onwards, you can consider if your unit thinks you would resuscitate the 22 weekers. 23 weeks is again a borderline zone where the parent's decision would make an impact. 24 weeks and above, and in the 34 weeks and above group, you have to be cautious when you use it. So it can be used right up to 39 weeks, but 34 to 39 weeks is a borderline group, and under 24 weeks is a borderline group where individualization is needed. 24 to 34 weeks is a routine.
Ijlal claims that although the postnatal survival increases, but he claims that there are some long-term survival, or post-puberty, some kind of complications, or whether the survival is actually equally as good post-pubertal.
I mean, this 12-year follow-up study I presented in the end did not comment on any other morbidity. Hopefully, they would have picked up on such findings if anything was prominent. So,
a similar question burning to me as well here. The mechanism of action of these steroids. Regardless of its anti-inflammatory effect. How does it help preventing the RDS?
So it's mainly the surfactant effect, but the anti-inflammatory effect or the membrane stabilization effect contributes. So the composite outcome is benefited by the other effects, but it has the stimulation of the messenger RNA for surfactant production. That's why the 24-hour effect is better than the early effect. And it also stimulates the release of the stored surfactant. So most of the effect comes from direct impact on surfactant production and maturation. The additional benefits, especially the extended organ systems like IVH, NEC, comes from the anti-inflammatory and the membrane stabilization effect.
Okay, there are few more questions, so we'll be grateful if you'd be able to.
No problem. You can email me.
Yeah, and I may just remind the audience that Dr. Sridhar is very active online, really. He's got a lot of educational media on YouTube and other places, so he'll be very happy for you to access them at any time, really. Thank you very much, Sridhar.
Thank you. Thank you so much. In case you want to access it, just enter Sridhar K on YouTube and you'll find it. Thank you.
Thank you.
Thank you so much.
Thanks.